Hey everyone, welcome to the CPTJ podcast. I'm Ashley Bergeron, one of your co-hosts, and I'm here with Blaise Robson, your other co-host. Today we're diving into a topic that has fundamentally shifted the landscape of critical care rehabilitation, early mobility in patients requiring ECMO. During the COVID-19 pandemic, many centers were forced to radically rethink what was possible for patients on advanced life support. Out of the pressure came innovation, creativity, and a re-examination of long-held assumptions, and few people have been more at the forefront of the movement than our guest today, Kari DiVito. Kari is a cardiovascular and pulmonary physical therapist whose work helped accelerate the development and implementation of early mobility practices for ECMO patients, which is a population historically considered far too fragile to mobilize. Her article highlights how interdisciplinary trust, structured mobility algorithms, and risk benefit analysis open the door to getting these critically ill patients sitting, standing, and even walking. Today, we're going to explore how our team built an early mobility program for patients on ECMO and how COVID reshaped the pace of innovation. We will also learn about teamwork, safety, clinical thresholds, and what truly defines mobility ready in the ICU.
All right, everyone, welcome to the podcast. I'm very, very excited for our special guest today. I might be a little bit biased, but we got Kari DeVito with us, near and dear to my heart. Kari, how's it going?
Hello.
So yeah, we have Kari here today because we're going to be talking about something that for some folks can be pretty scary, which is mobilizing folks on ECMO. So we're going to dive into some questions going in. So how about first for the folks who maybe aren't as comfortable or aware of what an ECMO device is? Can you give us just a quick basic run through of what ECMO is and maybe some of the precautions or things you need to worry about with these patients?
Yeah, so ECMO stands for extracorporeal membrane oxygenation. And a lot of people had never even heard of it until the pandemic came around and it became so much more commonly used. But um, my bestie OT describes VA ECMO, or the kind that will bypass your heart if it's failing for whatever reason, as a heart on a cart. Um, But then it can also bypass the failing pulmonary system if necessary. And that's what it was used for so much in the COVID population. But these people's blood are circulating outside of their body. So it's a lot of teamwork that's involved with performing PT with these patients and lots of interdisciplinary communication and monitoring these devices to make sure they're okay. You don't want to accidentally pull one or have something bad happen to this life-sustaining thing while you're trying to help this person rehab. So people do think it's a little scary. And there's literature, like the old literature says, don't do it. You're going to kill this person. I mean, it doesn't say that, but in summary, that's what it says. Like you're going to pull these cannulas out. Something bad's going to happen. Just keep them sedated, keep them in the bed, and just wait. Like figure it out later. Rehab later. But we know that bed rest is bad, you know? And so we have actually had a lot of success waking these people up and getting them out of bed, even with a failing cardiac or pulmonary or both systems.
Mhm. Well, speaking of pulling things out, which we don't want that happening to cannulas, I did bring a little something something because 'tis the season and all that good stuff. Here we go. And I have no idea how this is going to look on camera or if I'll be able to hear you or do anything with this. David, don't cut this out. I deserve this.
And with the Hawaiian shirt. Yeah.
So, and funny thing about this Hawaiian shirt, Carrie, uh, I I bought this and wore this one because I remember that your favorite color was lavender or purple. So this is my first time busting it out.
Wow. Thank you so much.
Hey, thank you so much for being here.
Thoughtful.
Look at that.
It looks
Oh man.
nice.
Does it look good?
Yeah, and I think this will come out before Christmas. So if it's after, Christmas in January or July, you kind of look like a Christmas in July guy.
I would.
Carrie, so can you give us like a little bit, like brief 1 to 2 minute summary of the key points of your article, and then we'll dive into some questions with you.
Oh yeah. Oh man, my elevator pitch, right?
Yes,
Oh,
exactly.
um, our institution has published a few papers actually under the title Cannulate, Extubate, Ambulate. And so we have one from the physician point of view, there's one from an anesthesiologist point of view, and then there's mine, like from a rehab perspective, how can we get these people moving? And then each of those other two papers also comment on like what how they consider us and how mobilizing with these patients is so important. And it is a central part of our motto um, at WVU. And so the motto really gets people to buy in. Like, cannulate, extubate, ambulate, baby. Like, that's right. We got to work together and get them up and get them better so that they can get out of here. And part of that is us reminding ourselves that they're people and not just patients. And like whenever I've had the chance to go out and teach people about it, like this is the person who sits behind you at church. This is the person who you're yelling at in traffic. This is like the cashier at the grocery store. Like they have life roles and think about all the things that you are outside of being a PT. And so we adopted that motto, like we got to get them moving, one, because it's going to help them medically, but also so they can be a person again. And critical illness can affect you for so long if you let it. And so if we can intervene really early and try to prevent all those physical things that can happen to you while you're on bed rest, hopefully you can reduce the amount of PICs that you have, be able to go home from the hospital instead of going to rehab, and get back to that life that you were once living prior to whatever it is that brought you into the hospital. And so we get as many people awake and upright as soon as possible. We've had patients who are cannulated for ECMO out of bed on day one, even. And we try to get them ambulatory in the first week or two, even if that means we have the vent and the CRRT and the nitric oxide and everything under the sun. But because all of us have adopted like our cannulate, extubate, ambulate motto, everybody has a job, everybody has a role, and everybody feels like they're part of this patient's recovery, rather than I've talked to a lot of people who are like, well, respiratory would never help me with that. Or the perfusionist would never help us do this. That's not their job. They watch the machine, they watch the vent, they whatever. And so we've just adopted such a culture of teamwork that we've seen some really great outcomes with these patients who are cannulated.
Hmm. And so I think you touched upon something before with the motto, looking at anesthesiologist and surgeon. Speaking of that, I think I saw Dr. Hayunga's name on this article as well. He's one of the thoracic surgeons we have at Ruby.
He's our
What,
ECMO
what,
director.
yeah, and what was it like formulating research alongside that discipline?
Yeah, and people
Yeah.
ask me that too, like, do your surgeons know about this? And I'm
Wow.
like yes. Um, a lot of that happened. We actually have gotten the chance to speak side by side a few times this year. And I remember there were two different times where someone was like, and what does your surgeon think about this? And I was like,
He's right here.
he's 2 feet from me, like he approves. But it was him when he was coming in 2018 to even start the program that was like, I want these people to move. Like, let's figure this out. And I'm on board. I trust your professional judgment. Like, it might be some trial and error, but he's a he's a special human. Like,
Mhm.
he's incredibly kind and values what each professional's clinical judgment is. And so I feel really fortunate to be able to work side by side with him. And, sometimes he'll just text me and be like, I'm proud of the work that you do. And it's like,
Wow.
there is
Oh,
no other surgeon who would ever do this. Like, or just like sometimes I'll get an email like, I heard somebody saying something positive about our ECMO program and how well they move. Like, thank you so much.
Hmm.
So I think he's just a unicorn.
Hmm.
And it has been, he has really opened up a lot of opportunity for me and was just like, if you're willing to figure this out, I'm here to help you and find opportunities for us to improve and teach others. And definitely not something I thought I would be doing in this career.
Mhm. And so we had recently talked to the folks at Utah with their clamshell protocols, and they had mentioned how great their experience is having, physicians and other disciplines backing them. What's your experience been like working with him? And what does that do for you when you're out on the floor compared to, you say you go somewhere else and maybe you have a care team that isn't as much of a proponent of PT as you'd like them to be?
Yeah, and I have, because of this article getting published and other opportunities opening up to go teach at other places, or even just consult like on the phone with other hospitals, I have heard other PTs be like, well, our physicians don't even know that we can go down there and go into the ICU. Like, what would we do? And I talked to a PT earlier this year, and it was him and their physician like trying to get into more ICU and like not even ECMO, but just like trying to get PT in their ICU in the smaller hospital. And neither of them had heard of like ICU liberation or like ABCDEF bundling. And I was like, man, that's the standard. So I understand other people's frustration and I hear them like, well, so and so would never get down with that, or our whatever team would never support us in that. And I just can't imagine because I've had such a different experience. And now often those are coming from non-teaching hospitals, maybe like smaller community hospitals where it's like, man, these patients aren't even awake or they don't move or whatever. But it seems like being at a teaching hospital, everybody is like, well, if we want to be the best and we want to do better and we want to advance practice and be like, yes, West Virginia University, they're doing the best. They're moving these patients the most and trying to advance practice in all these different areas from all different parts of the team. Like, we support each other in every single way. And yeah, and my relationships with other like attending physicians who have been there for years and years and years, they call me by my first name. Like, I never expected that.
Mhm.
And it's like, oh, that's Kari. She does this. We respect her opinion. We know she's going to help us. She's going to be able to help us figure that out. And yeah, I wish everybody had that same experience because I have learned that it's not that way for
Mhm.
everybody.
And so we talk about how important it is to address these folks on ECMO. And actually, I might dig into a little bit of some of the questions that you put down. And
Yeah.
if you want, and actually, if you just want to tell me to shut up,
No,
you can just tell me to shut up and ask whatever you'd
it's
like.
okay. How many times do you get to interview your mentor? She's probably usually interviewing you.
That's true. That's
Mhm.
true. We are gonna see if this counts as a mentor hour, by the way.
I think it should count.
Yeah, I think it should count. If Dr. McGinnis is listening to this, I think you should totally let this fly. So this is something that so at Ruby, we have a dedicated, pretty much a MICU therapist. And I know that research and even what they talked about this year's recent bit at the academy is to have dedicated ICU therapists. Um, Carrie, I know that we really don't have that other than in maybe one PT in one of our ICUs. Do you think that do you agree with what other folks have been saying that okay, we need to have dedicated therapists for the ICU? Like, do you think that the needs are being met within like our CV ICU? And I don't want this to turn into me being like hyper specific about us, but maybe from conversations because you've been in this game a lot longer than me. Like, is that something that's been in the talks for a while with the groups that you've been with? What's your experience, or like, what's some stories you've heard?
You
Yeah.
could think
So,
of it- Oh, sorry. I was
right.
just gonna say you could think of it more of like a pros versus cons of like having specific therapists stationed in a home in
Mhm.
the ICU or like certain floors versus like rotating every
Yeah.
day?
Yeah.
'Cause I
So
know
most of our therapists rotate.
Mhm.
So yes, we do have one, like our MICU therapist. She loves it. She's dedicated there. Cool. Um, we do have one dedicated like orthopedic person, and she's been in that role for years. There are two of us currently certified in cardiovascular pulmonary, one on the way, as long as he passes the
Hi.
test. Um, and so, well, the other specialists and I are kind of dedicated to the Heart and Vascular Institute. So our cardiac pulmonary and our cardiac ICU specifically. So I've been on the same floors for 6 years out of the 7.5 that I've been there. I was the MICU person. I wasn't having fun. Because the culture there was different. They they weren't buying into the everybody needs to be up thing. And so it was just so much more of a struggle. The physician support wasn't in that unit. So the culture can be different even within your building, which is wild to me, but it's a thing.
Mhm.
Um, and I'm kind of the unofficial dedicated ECMO PT because we have done research together. We've published a few things together. We've gone and taught together. And the building of the trust in those critically ill, like very fragile situations makes a huge difference. So when, not to throw anyone under the bus, but like if someone else tries to see a patient who is on ECMO, they come to me and are like, what are they doing here? We don't know them. What are they going to do? Like I like what we have going. If it ain't broke, don't fix it. You know?
So do you have like specific trainings for all the physical therapists to be able to mobilize people on ECMO since you guys all switch around?
So because two of us stay in that unit,
Okay.
there are like the myself and the other specialists feel pretty confident in those roles, but um, doesn't mean that someone else can't go see those patients. But the team usually doesn't feel as confident about movement of that patient or like wants me to be there with them or wants some kind of training to occur before that person is in there because the team, like the ECMO specialists and the nurses who treat the patients who are on ECMO are usually pretty seasoned, or the ECMO specialists have been there since the beginning of the program. And
Mhm.
so they know what they're doing. And since I've been with them since basically almost the beginning, like the trust does make a huge difference.
Okay, so sorry, Ashley, that segues into one of my other questions really well. So you mentioned like you've been down there for 6 years, and since the initiation of this protocol began, and then we hit COVID, where, like you said, we are ramping up the amount of folks that we're cannulating. How has that ICU culture shifted during the onset of this protocol up until now? And have you noticed that there's any carryover with other diagnoses on that floor too that isn't just specific to ECMO patients?
Yeah, so prior to the pandemic hitting, it was almost exclusively like myself and an OT who would be responsible for range of motion, stretching, getting the patient in chair position to reacclimate to upright. I even dragged the tilt table down there one time. There's not enough room in those rooms for all that.
Yeah.
It was a nightmare, but I made it happen. Um, and then like we still get them out of bed primarily for the first time when they get up. But when the pandemic hit, we were instructed, like if they're prone, paralyzed, still sedated, whatever, don't go in there. Find the patients in the building who are awake, going to get the most bang for their buck, and expose yourself to the virus less if possible. So, okay. But these patients with ECMO, they were like, well, is this a different strain? Why is this person way more sick than the person next door? And do we need to keep them in isolation longer? Should we be wearing different PPE? Uh, we just didn't know. And so then it's like, well, I have this instruction on one hand, don't go in the room if they're not awake from the rehab side of things. But then, like, well, who is going to move these patients? Because it's usually PT who moves with these patients. So there was this weird balancing act at first, but then we informally trained nurses and ECMO specialists, like, here's how you're going to protect your body to do range of motion with these people. Or like, here are the muscles that primarily get um, stiff and they lose flexibility in while they're on bed rest for who knows how long. Here's how you can stretch it. Because they have to go in the room for some reason throughout the day. And so then they just incorporated stretching, like some kind of full range of motion of each extremity every time, like at least once or twice a day, something. And then they got really into early tracheostomy. So they were getting trached on day anywhere between day 4 and 7. And so then they were waking them up. And so then my whole day was going room to room, ECMO, 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 because they were all awake and they were all ready. And we were just working out with some of these people. Like they got so well physically. I had one guy, I would see him for like 45 minutes every day because he had physically gotten so much stronger and he had the trach, so he was able to eat and he's talking and he's just trying to keep himself busy. He's like, can we work out while his lungs are trying to heal? We're doing like stairs in the room and like I would bring a step in and we would go Richard Simmons step climbing and all the like we were picking up things off the floor. I would bring him all the resistance bands. He was doing like bicycle crunches in the chair. I mean, we were doing everything while they were cannulated, but within the confines of the room, which they had taped shut, by the way,
Oh my
because
God.
they didn't want the ECMO COVID to get out because what if it's a different strain? It was a wild time. Um, but the carryover has been, well, the ECMO specialist and the nurse got more practice moving with these patients or like getting the bed in chair position or more practice getting them to the bedside commode or to the bedside chair. And so now they're like, well, we got them up to the chair already. We knew you wouldn't mind. Like, we know how to do it now.
Yeah, and I can just speak that the coordination within that culture is insane. I remember going in, I think it was as an elective in PT school. And I went in with you and the OT that you were speaking about, and I just saw one, how much space all this equipment takes up in a room. And I think that those rooms typically they're bigger than any regular other room. Like it's not small by hospital standards by any means. And then the amount of folks that it takes to move everyone. And I just remember you saying like, "Hey Blaise, you can hold the cannulas if you want." And I was like, "Oh, I don't know if I should. I really don't know if I should." I was like, "Oh, this is way warmer." But it's way warmer than I thought it would be. But it is crazy how coordinated. I don't think I even now. Ashley, your experience might be different, so please jump in and tell me if you've seen experienced anything any differently. I don't think I've ever seen that many active clinical professionals working at one task in the entire time I've been at PT, and it's
Such a
super
true,
gnarly to see.
true interdisciplinary like session, 100%. I agree. Which that does make me think of a couple different questions that I had based on the article. And I'm wondering if it's still like the same to this day. So I saw in your protocol, usually you were seeing these patients 2 to 3 times a week. And so now I have the idea that everything was done in the room. So I think that that gives me a little bit better idea of where this is going to go. But for nursing-led mobility, on the other days, were they also getting them do like sit to stands in room or step ups or anything like that? Or was it more like bed to chair sort of mobility the other days and you guys were doing more of the harder task?
We typically did the harder things, but then, so every time, every time you see somebody, you're making like a new assessment of what their abilities are. And so then we would come out and be like, well, they actually didn't need any help to do whatever, however many transfers, sit to stands. Um, we did stairs. Did the stair 10 times and their oxygen saturations were good. Their blood pressure was good, whatever. So I think you guys could maybe run through their resistance band exercises and gave them like a home exercise plan, or like, can you encourage them to do this? And some of them, like when they would see them move, the patient move successfully with us, they're like, oh, okay, I see that. I think I can do that. Here's how they set, like, go in with one or two people, or take the Sarah steady in and do three or four sit to stands with this person before you get them to the chair. So there was so much carryover. We would just come out and say, I think they could do this with you later. And that made a huge difference. Um, that eventually, after the first batch, they came out of isolation in 15 or 20 days or whatever it was. And
Mm.
so we would eventually, or was it 10 days? I blocked it out. Um, we would get them in the hallways, and they were, we were walking 8 feet in the room on the first try, or 1,000 feet around the entire unit when they were out of isolation. And we just did as much as we could. And some, especially the boy ECMO specialists, would be like, guess what? We stood him up 6 times yesterday. And like, I love that you're so proud of yourself, but that helps me out more than you know.
Okay, so they were getting like high quality mobility on the days that you guys were not seeing them. Because whenever I read it, I was like, oh, maybe it's just like up to the chair. And then are they actually like progressing the days that you're not seeing them? So it sounds like your team was like really on it and trying to get them to progress whenever you weren't. Like,
Yeah, they were at least getting practice every single day, as long as they were medically stable. They were up every single day, not in the bed. Once they were medically stabilized enough, we're up. Even if they had to use the mechanical lift. And then some people have come to me when I've been teaching at other places, and they're like, well, you can't use the lift on these patients. Something bad's gonna happen to the cannulas. Like, that has not been our experience. We use it when we have to, but often we try to intervene before it comes to that point. And so the early mobility and the carryover of all of our interventions is what helped us. We had the highest survival rate at our institution in 2020 and in 2021, 70% survival of the patient who had COVID and needed ECMO. And then we had the highest um, discharge rate directly home. So ELSO reported that an average of 30% of patients who had COVID and needed ECMO were going directly home, but we had 60% go directly home. And so I can't prove it, but I feel like those things are directly related, that we were getting you physically ready, even though your lungs weren't healed yet. But in the meantime, while we have this support, let's work out. You want to work out? I'm your girl. You want to be able to carry your laundry basket down the basement stairs to do your own laundry? Let's practice right now.
wow.
Let's
You
do it.
guys were doing everything in the ICU. It was not just let's walk a lap and then we'll go sit down. You were making it super functional.
And like once the patient can walk without us clinging to them for dear life, without their knees buckling and everything going awry, like I'll come in the morning and the ECMO specialist will be like, "Well, they walked with night shift, and we're gonna plan to go again at 10, and then we're gonna go again at 2." And like they'll have them in the hallways 2 or 3 times. And I'm like, "Well, wait for me." Like,
So
and so
your team will
that's
like lead
even
walking
now.
sessions. Oh, I'm sorry. I interrupted you.
No, I was just saying like that was then it was COVID and that's still now. I'm like, well, I want to do stuff like wait for me. But yeah, so what do you want to be able to do? And so then we'll work towards that. You want to put your own socks on? Amen. You want to be able to stand and do your own makeup? Okay. And so then we would ask them those questions. And then before they went home, we'd be like, all right, let's go through the morning routine. You got to climb 6 steps to get in the house or like down to your main level or whatever. And if you wanted to stand long enough in the bathroom mirror to do your makeup, all right, let's go try it. Let's let's get dressed. Let's do all look like we had the highest survival rate of new mamas who
Wow.
needed ECMO for their COVID, and those babies came out just blue and gray and survived by one miracle. And so then it was like we had all these young ladies who were entering motherhood and critically ill, and like you're entering a whole new phase of life and I have to train you up for that. So we would like tape the blankets together and shove the cuff weights and carry our like fake baby around because this girl has to do that when she as soon as she gets out of here. And so yeah, what do you need to do? And that's what we worked on during therapy sessions and the team just took off with transfers to the chair, to the toilet, in the halls, whatever.
And s- and so could you paint a picture for us? Because it's really neat to see. What can you walk us through a typical session? So how the PT coordinates with the other disciplines. What do we take a certain type of leading role when we're going through? So can you give us a little walkthrough session of maybe a patient that can get up and, maybe just say take a lap?
Yeah, it does take coordination, and that's where it's different than most, like your average acute care session where you're like, hey, nurse, is this person stable? Anything I need to know? All right. This is like, what time is good for everyone? Are there any procedures that are happening today that the person would have to be in bed? Like, let's make this worth our while. Oh, the respiratory therapist has to do a bronch at 10:30. Could we do it at 11? Can everybody be available at this time? And we'll plan on getting this patient up. And so we set that up in advance. And then the nurse or the ECMO specialist, and not all programs are run with an ECMO specialist. They might have a perfusionist at bedside. But one of those team members goes in and gets the patient like to chair mode. And so are their flows staying stable? Um, are their vital signs staying stable? Are they having symptoms? And then they'll let them simmer there for a little bit, make sure they're okay, and that all the equipment is functioning properly and the patient is fine. And so then we'll come and we'll get them out of bed. We often transfer from chair mode because we have stuff on both sides of the patient. And so then we can just bring it forward rather than trying to get the patient edge of bed. We have done that. Um, we just seem to coordinate better when we do it from chair mode. And then maybe if it's the first time, maybe can we weight shift? Can we step in place? Is this patient's knee buckling? What's their vital signs doing? And so everybody has a role, and we don't even have to talk about it anymore. But initially we did. Like the nurse is like, vital signs are stable, or the ECMO specialist is calling out, flows are stable, or the respiratory therapist is like, oh, this line is getting tight. Hold on, like let me get a little closer. But during us when we're in the room, we are generally the leader. And so we say our plan is to do this, and everybody knows what their role is. If we're going to go take a walk for the first time or whatever, everybody is still like, all right, I know the nurse is going to tell me about the vital signs, the ECMO specialist is going to tell me about flows or if anything is going on with their equipment. And then I'm calling out if anything's happening with the patient. Oh, they're becoming less stable. We're actually having to help them a whole lot. We need a break. Who can we bring the chair in? Um, And then you just have to be confident calling that out.
Mhm.
And you can't be the introvert during a PT session with these patients because I mean, it could be life and death. We haven't had any like catastrophic events, but it could happen, that something goes really wrong. And so if you're like, oh, well, their oxygen saturations are dropping, but I'm just gonna wait and see what happens. That's not gonna work. So you have to take the charge and be willing to call out, what's going on because we have to keep this patient safe. And that's like the teamwork is what makes it so great. Whereas like nobody's afraid to be like, I don't think we should do this because, or I think we should stop because of this. And we all just respect each other's decision making to be able to like, yeah, all right, you're uncomfortable, I'm uncomfortable. Let's not do it. Or let's stop here.
And so what does your pre-safety checklist kind of look like with like cannulation sites and then anchoring and then also like typical vital signs that you're seeing and then also parameters on ECMO? Like are you also kind of diving into that and having discussions with the physicians and the specialists, or are they kind of the ones who just kind of tell you maybe not today, or can we like have a discussion?
They can tell us not today for whatever reason. And like again, whatever their judgment is, totally respect it. If their sweep is higher than 6, so we're really doing a lot of work to remove CO2, then we often will hold on like trying to walk, like anything really taxing. But like if we sit the patient up and their flows decrease and the ECMO specialist lets me know that, then well, is the patient having symptoms or not? And if they are, then we might go back to supine or um, maybe decrease our hip angle a little bit, like if it's femoral cannulas. But if they're not symptomatic, then we have this agreed upon, like we'll keep going unless the flows are really diminished. Um, but then at that point, the patient's probably having symptoms.
Mhm.
Um, as long as their, vital signs are relatively stable. And some of them have different like SpO2 goals, but like is their map appropriate? Or did you set them up and their oxygen went to 72? Well, maybe we shouldn't do more.
Mhm.
But I don't know. I almost forget what you said. But no, but sorry.
I asked like three questions in one for sure, because then I was like, oh, there's so many things to think about. So my other part of the question, which you answered that the first or the second part beautifully, so thank you. But the first part was kind of like your safety checklist, like checking the cannulas, anchoring, like kind of what does that look like whenever you walk into the room? What's the first thing you're doing? And do you like kind of go down like like a checklist, kind of?
And well, so our ECMO specialists actually they have checklists on the machine.
Oh, great.
Yes, and it's like, all right, do we have a full oxygen tank? I don't know whatever they're looking at. Make sure you unplug this. Make sure you unplug that. Like, are the cannulas free and clear from the bed? And we don't do any moving until everybody says that they're ready. Like, all right, am I all right to start moving the angle of the head of the bed? Are we all right to stand? Does everybody feel like they're in a good place? Um, but when I'm in the room, I've already had these conversations. Like, have things been stable thus far? And so hopefully we're ready to go in there, all of us together, and be successful. Um, and we just take it very stepwise. So we set them up. Well, what was the response? Should
Mhm.
we keep going or not? Or just the other day, I pulled back the guy's pillow. And so we apply this protocol, PS, to everyone. Femoral cannulas, where it doesn't matter. And people question me on that a lot. So I've learned that a lot of centers, if they have one femoral cannula, they're out. No, no therapy until that's gone. Um, we haven't had any issues with it. But, however, caveat. The other day we did have a guy waiting on a heart transplant, and one of his there was a small crack in the cannula. And so I pulled the pillow away, like everything was going fine. And we're like, yep, all right, let's get him out of bed. And I pulled, he had a pillow under his arm and it was kind of over his lap. And I pulled the pillow away and the whole bottom was covered in blood because it had seeped through the dressing. And so then we were out.
She said, "Peace out, guys."
So, all right, you guys fix. I don't do this part.
It
When the
was not
blood
for
is,
mobility.
yeah, this is not appropriate. But
Got got that contact note in so quick.
that's right, not appropriate. They did have me come back though. They stopped the bleeding. They fixed it. And we use something called a pancake dressing. I don't, I think that's just a glorified name basically for something that you've seen the dressings that hold like the Foley catheters,
Yeah.
sort of
Yeah.
like that. And so they put those every like 6 or 8 inches. They used to sew the cannulas like right into the knees.
Hmm.
And everybody would be like,
Oh,
oh, it hurts. Like, oh, does it?
oh my God.
It does. You
That'd
mean
be
there's,
really hard with mobility. Like, oh my
yeah.
gosh.
And
Yeah.
so, I mean, directly on the kneecap, man.
Mm.
Come
Oh,
on. I mean,
that,
the
makes my
skin would
skin
be like
crawl.
pulling off of this patient's knee, and they're like, I don't know, I just can't bend it very much. Like, so they use these pancake dressings instead now, and they just use a couple of like one above and one below the knee, and we haven't had any issues with like cannula movement or displacement, whatever. And most of so it was like 53% or something during the pandemic had a femoral cannula. And we still moved with those people. And then they started doing like the crescent cannula, the dual lumen up top here. And then there was no pain in the knees, which was great. But just because there's a femoral cannula, it doesn't stop us ever.
Mhm. And
Unless it's
so,
bleeding.
go ahead.
I was just saying, unless it's bleeding.
Yeah, that checks out. So, I mean, we've been talking so far about something that is one, cardiac patients are relatively scary for all PTs. I don't see why. I think they're pretty fun. ECMO is just another level above that. And so, what's your feedback been like from PTs in the field when you're telling them, yeah, I'm actually getting people up who are not only a cardiac patient, but their heart and lungs are working outside their body? Have you gotten any pushback, any positive feedback, negative feedback going through? What's your experience been like since
It
writing
goes
this protocol?
one of two ways. The patient or the PTs who work at ECMO programs, who are mobile, who have like that teamwork culture in their ICU are like, "Ah, thank God you said it because it's not that hard. Like
Mhm.
if you just talk to each other, it's not that hard." And like and so they're either super supportive, like, yes, thank you for saying it in writing. Thank you.
Mhm.
Or it's the person who's like, are you sure? Is this okay?
Mhm.
Like all of our patients are sedated. I had a PA from a hospital in a nearby state, and, and who was like, "You're not doing that." I was like, "You think what? What do you mean?" And she was like, "Well, every single one of our ECMO patients is completely sedated. Like their muscles can wait." It's like, no, they can't.
Mhm.
And Um, I was doing a speaking engagement where a nurse, let's see, she was a nurse by trade, but then she got into an ECMO role. And she was like, she spoke after me, thank goodness, because she was like, well, Carrie already said this, but we didn't know at the time that if you get patients up, like it helps them medically. Like,
Mhm.
oh, their lungs can expand more, like the diaphragm can move more, and like their organs aren't inhibiting diaphragm motion, and they have less atelectasis, and they have better airway clearance when they move, and they're less delirious. And it took us so long to figure that out. I'm like, you should have asked your PT, man. We know this stuff.
Yeah, I find it crazy that we know more than we think, and we just don't speak. I just don't think as a profession we speak up enough because for us, I even think prior to doing this residency or even being a specialist, this is just commonplace knowledge for us. It's like, oh yeah, of course. The more you move and get up around, the more secretions come out, and we try to work your diaphragm a bit more, like on and on and on. So, do you think that pushing this type of research has been beneficial for you and your immediate sphere in the PT world? Have you noticed any gains?
Yeah, I think so. Because I think maybe even in acute care, for example, my mommy thinks that I do exercises in a gym with mammas in their PJs all day.
Sounds like us.
So, yeah, and I want to take your mom to work day. I don't know who I have to clear that through, but that's what I want. And so I think that the general idea is that PT is like outpatient PT, no matter where you are. You're in the gym, whether you're in your jammies or your workout clothes. um, and so then, yeah, people see now that I know so much more than you thought I did. I'm not just like a gym rat.
Yeah.
I am, but not only.
There's more to me than my rattiness.
Don't call me ratty, man.
Cool.
Yeah, so I think people just have more of a respect for what I have to offer. Or like if I'm doing airway clearance stuff, like, oh, I didn't know you could do that. I thought the respiratory therapist did that. Or if I'm trying to show somebody, even, day to day, like, we got to use that incentive spirometer. Have you used this yet? Well, you're using it wrong. Like, and here's how you do it. Or even today, there was a respiratory therapist who is new to me, and I needed the Venturi mask for somebody who had the ventilator on. And I'm like, well, we're gonna go walk in the hallway and do this, and I'm gonna set the venti up. But I was just letting her know
Mhm.
that I was gonna touch her toys. And and she was like, "Do you know how to do that?" Like, yeah, I
I
feel
got
good
the
about it too,
Yeah. I got the same thing when I've been trying to work on my auscultations with lung sounds. I had a nurse, I was in the ICU, and I pulled out, my back clip on the
Yeah.
side that I have, my utility belt, and I started taking them, and she's like, "Oh, I didn't know you guys even knew how to do that." And I was like, "Huh." At least I pretend like I know what I'm doing. I have no idea what I'm hearing right now.
I hear
But
things.
yeah, I hear things, but it's so neat to hear you and other clinicians who really show everyone else what we're capable of. Because we do a lot. And it's neat to see that we have someone who's a trailblazer that's running ahead, trying to push things that ultimately benefit our patients, which is what this whole thing's about. And do you have any stories that stick with you from these ECMO patients that maybe you had seen during the time of this paper being written or afterwards?
So we recently had like a survivors luncheon, and they invited everybody who had survived at any point, pre-pandemic or post. And a bunch of them came, and we got the team together and we started taking pictures with each patient. And there were several like Wizard of Oz moments, like, and you were there, and I remember you, and you got me up the first time, and you yelled at me and told me that I have to move. Like, I didn't yell at you, but maybe I did. Like, um, and yeah, so it was just cool. And some of them just like, man, thanks for that tough love because they get so down and depressed and like, I'm not gonna make it. My blood's on the outside for God's sakes.
Mhm.
Like what's left for me? And so then I have to come in and be that optimist, like, no, no, we have to do this. Trust me, we have to do this and work through so much anxiety, fear, depression. And then they're like, oh, thank you.
Actually, that pulls up a question for me. And Ashley, I promise you, you can ask anything else you want after this. I will mute my mic. I'll bite the ball at the end of my hat.
Oh my God.
Because we always talk about what we have to do as clinicians to mobilize these patients, and we know like the benefits. How do you convince your patient who has their blood feeding outside of their body, that have, lines upon lines connected to them. Everything hurts when they move. What's that like for you as the therapist to coach them through that, but have them buy into what you're selling them? What's that experience been like?
It can be really tough, and it totally depends on the person. Like some people were super active, and then this thing just happened to make them very sick, and they're like, "Get me out of this bed." Like, say no more. But then
Mhm.
there are other people who were really sedentary and not well to begin with, and like, no, I wouldn't walk this far on a regular day. Leave me alone.
Mhm.
But it seemed like if we could intervene and like they're out of bed and they're trying to do all these normal things before the anxiety and the fear sets in, like they can have some successes and then it's like, all right, yeah, I'm good. Or a lot of time, well, my problem is that I'm a little girl. And so
Yeah, for
critics,
everyone who doesn't know, because you can't tell with the camera, she is so much fun. She's so strong. But Carrie, how tall are you?
I'm 5 foot half an inch.
That half inch counts.
It does.
Yeah, I was gonna say I can relate because every time I go in there, like, we need a man, but I am 5'6", so I have a few inches on you. But then I'll do like a total assist transfer of them and they'll be like, oh, that was you. And I'm like, I told you I could do it.
I'm
Yeah.
con Yeah, I'm convinced Carrie could hip toss me. We are in West Virginia that she could hip toss me to Kansas if she wanted to.
Oh my God.
I'm not messing with her.
So
Yes,
much power.
yeah, I'm sure that you get it too. Like, you're just a little girl. We need a big, strong man. Oh, and sometimes it'll be like, well, it took two big boys to get me out of bed this morning. What are you gonna do, little lady? Like,
But we have the body mechanics and the knowledge to know
yeah,
how to work with it. And then
these
I
are,
always love whenever because we have PT techs for the ICUs, and sometimes it's also a smaller gal, and she'll come in and they'll be like, "That's your help," and then we do everything just great, and they're like, "I should not have doubted you."
yeah.
And sometimes our PT techs are like 6'5" dudes, and then they're like, "That's what I'm talking about," and then that makes me sad because then I'm like, even though they're all great
Aw.
text, don't get me wrong, but I'm like, us girls got it.
I feel you entirely. I'll either go with like, well, dynamite comes in small packages, pal.
Oh,
Or
love
like,
it.
or- yeah, they need to be successful with you one time and then be like, all right, I'm sorry.
hmm
But sometimes, like the fear and the anxiety play such a part. And like I had to go look up like coping strategies or like how to ground yourself back in reality rather than like, well, what if I fall or what if this comes out or what if this pulls or what if this hurts? And like, let's come back to right here, right now. Like, you're in charge of these emotions. Like, let's flip the script and let's say something positive about this. And then like one or two sessions later, they're like, all right, I'm cool. You know? Also, bribery.
Love it.
We
So
had one gal who would work for Purple Gatorade. I'm like, all right.
purple, very specific.
Out of all the Gatorades, purple?
Yeah, they have purple Gatorade. It's like maybe grape flavored.
Oh,
She was
Comes
into
back
it.
to the thing we were talking about at the beginning, which I don't even think was recorded, the grape thing on your desk, and now we're at
the grape
purple.
squishy.
You're
Yeah.
welcome.
Thank you.
Anyways, on this topic, of you kind of like helping them with their mental battles, do you guys have any sort of like PICS clinic or resources after they're out of the ICU or after they leave the hospital, to kind of help them through anything that could come along after they're gone and don't have you guys there every day with them?
Yeah, so the official PICS clinic is like still in process. It's a thought, it's a thing. I know they ran into some hiccups with like financially, how does this work? And how do you coordinate this many professionals to come be able to see this patient, like psych and pharmacy and social work and PT and OT and like how do you take all of those people away to bring them down to this clinic and make it work? So I know that there were some hiccups there, and they were talking to some other hospitals who have implemented like a PICS clinic. But at the moment, we have, I think it's quarterly survivors calls. And so they all get like a Zoom link. Um, they can even like call in and talk to an ECMO specialist or the ECMO coordinator or something if they have specific concerns. I know that one of the specialists was telling me the other day that like she had one of the survivors reach out to her on Facebook, like, "Hey, I'm having trouble with this. Do you know what's a resource I can do for that?" Um, but yeah, hopefully an official PICS clinic coming soon. And then we just did that like survivors lunch where they all came in and they shared their stories, and they'd done that once before. I think that was pre-COVID, and so then it went away. But and that first one that we ever had in person was they were able to bring one of the currently cannulated patients to that room where they were having that meeting. And it was just so encouraging to be like, this is not the end.
That's awesome. I love
Yeah.
whenever there are people who volunteer to come back and like chat with
Yeah,
actually nice you about their experience and be like, I'm out, I made it. That seems like really empowering
for sure.
to the patients. And that's been something that I've really appreciated, at least where I am, because I feel like that would be something that I'd want if I was in there. All right. I do have two more questions that are not exactly on this topic. And then Blaise, if you have any more, you go for it. And then we have some rapid fire questions for you because I know it's getting kind of towards the end. So one of them, I know we had chatted a bit about survivor rate and how many people you were able to send home. And I did see the parameters for those who were on VV ECMO included those less than 50 years old. So I was wondering if that's still like within your parameters or if you guys also do ECMO on people older than 50 or if you guys just use people who were 50 years old for your study and there were people who were older than that actually on ECMO during that time.
That's actually what the final parameters ended up being during the pandemic because they did cannulate older folks. And I was like, oh, this isn't going well. And so then ECMO became a scarce resource. They were turning down a dozen patient referrals a day.
Wow.
And so then it was like, okay, who has the best chance at a meaningful life after this? And so then the age range just kept decreasing. Um, so that was what like the end. Like, all right, they got to be less than 50.
Mhm.
Um, but now, I mean, we've done, let's see, I've seen anybody in their 70s through 12 years old.
Wow.
Yeah. They have like infant ECMO.
Mhm.
I don't do
Yeah.
that. Count me out. And the 12-year-old that I saw, I've seen a 12-year-old, I've seen a 14-year-old. They were adults. They were as big as me.
Mhm. So it wasn't like working with a small child with that.
Right.
Wow. I got the opportunity to go and observe and kind of help out in the cardiovascular pediatric ICU whenever I was a resident at Duke and seeing people mobilize children on like ECMO and RVADs and things like that whenever they're literally like tugging at their stuff and
Yeah.
like games and like I was like I thought doing this with adults was like a little bit, can be a little nerve-wracking. And then seeing that with the kids and everyone was so chill and so calm and I'm like, "Oh my gosh, I would be losing my mind." I feel like just like a little bit. It takes definitely a different special person who is
Yeah.
not me, I think,
The
for that.
14-year-old that I had seen was like way adult size compared to me. And
Mhm.
so they had her in the adult unit, but it was last year that I saw like that 12-year-old. And that was the first time they had ever gotten a child out of bed. And they took me over there, and I swear to you, there were no less than 50 people in the room. They took one of the adult ECMO specialists is also PED certified, and he calls me up and he's like, I need your help. And I'm not a PEDS girl. I didn't even know where the room was. And and there were just a million people at the door and just, oh man. And it was like, oh, okay, they're doing this. Maybe we could do it too. and so it's trying to start that process of change for the pediatric side of it.
Oh, that's lovely.
I
Okay.
think it's kind of crazy, and this isn't a question, but and I know it's something that I actually had written down, but it's really starting to hit me now is how awful the pandemic was, but how it was a catalyst for early mobility afterwards for everyone and all these different settings. It's kind of weird. It's a weird catch 22.
Yeah,
It's
agree.
hard to like know how different it would have been before the pandemic because like
Yeah,
Blaise, I was in PT school from 2021 to 2024. So I was in PT school during the pandemic, but I wasn't really practicing in any sort of critical care settings during it. So now I just see what's come from it, which is I'm very grateful for because I've worked in very pro mobility places so far and I really appreciate that. But I don't know what it would be like before, like pre-pandemic in these areas. And I've heard many stories and it sounds insane, but I just want to thank you and like all the leaders in ICU mobility for helping set the stage because I don't think I'd be able to practice how I am without you guys. And I'm sure Blaise probably feels the same.
absolutely. For sure.
All right. So we're getting close to the end. We have some rapid fire questions for you, unless Blaise, you've got anything else you want to throw out there.
No, I will put the white ball in my mouth and I will shut up
Oh,
until
no.
I'm just kidding.
I was gonna let you take it away. We have literally so many questions that I still want to ask you, but this would be like a 3 hour interview. So I'm
A
just grateful
three-parter.
for the, yeah, yeah, I mean, maybe we could have you back on. I don't know. That would be
I'd
cool.
I'd have to get another Hawaiian shirt. That's all I'd have to say.
I don't think that's a bad thing. But anyways, just very grateful for the time that we've had with you. So, a couple fun questions to end it. I'm gonna let Blaise take it away. We can do every other question. Go
I
for it.
I have three, and they're like the final three. So if you want to take the first few, please do.
Oh, okay, a final three. So I'll go for it then. All right, so these are some questions that we ask all of our guests that come on here. They're supposed to be rapid fire. We've had some people take a good 5 minutes on each one. You can do that if you really want to. There's no pressure. But if you want to try and answer them really rapidly, you can also do that. There's no set
Okay.
rules here. Very chill. All right. So, first thing, in your opinion, what is the most underrated clinical outcome measure? It can be ICU based, outpatient, anything.
Oh my gosh, outcome measures. Oh,
Yeah. Do you do
um,
those in the ICU very often?
we we are doing them.
Okay.
So
Yeah.
There we go.
yes. Um, Man, I've really liked. Been way more consistent in the ICU, like trying to figure out how to manage my hands, like for the stuff and the patient and get the gate speed. Like that really makes me feel like I'm doing something.
Yeah.
Like,
Usually have to stop and be like, hold on, and then do it
yeah,
and be like, okay, continue. But then it's
yeah,
not accurate because it takes that second.
Yeah.
And just subtract. You know.
I always get nervous because if I have a nurse that's working with me or an OT or whoever, and it's a really unsteady patient, I put on a voice that I don't like to do, but I go, "Could you get a stopwatch for me?" And it's like super serious because I'm not a serious guy at all. And they're like, "Oh, something's about to happen."
This
And I
is
go, and I was like, "When I say record, please start it. Whenever I say record again, please stop it." And it just makes me, ugh. I don't like being adult and grown up. Ugh, I don't know how you guys do it.
but yeah, I'm loving doing the gate speed because it
Me
does tell
too.
us so much, and it takes me like just real quick, boom.
Mhm.
Yeah, like, and then I feel like there's pushback sometimes. Like, who cares? Like,
I think it's a good measure. I would agree. It correlates with so many different things like fall risk and lower extremity strength and then cardiovascular endurance. And it's so easy to do in any setting. So then it carries across the board. So I would agree with that. Great outcome measure. All
Sixth
right.
vital sign.
right.
Yes. All right. So next thing, one book every PT should read.
Ooh, I don't know, man. Yikes.
I think everyone else has been going with one of these bad boys.
We actually have had that.
I actually bought the 11th edition too. I don't know where it is. It looks way cooler. It's used on Amazon. $26. Go get it. Spiral bound.
They're
Oh,
not sponsoring you.
I know. I keep gunning for it. Between like the Hawaiian shirts and the ACSM team, I've gotten nothing. No feedback.
and that mushroom coffee that Rich had.
Oh yeah, that's right.
Nobody's responded. So we did just put out our first episode. So
So there's still time.
time.
Oh,
How
man,
about what's the last book that you've read that you really liked?
it was a murder mystery.
Okay.
Oh,
Okay.
okay.
That's good to like let your mind go somewhere else besides physical therapy.
And
Yeah.
cannulation, you know.
What was
Was
the
it
book
the housemaid? And now
house?
the movie's coming out this
Yeah.
week.
I've heard really good things. Okay. That's
Got me.
okay. Next thing, you're getting ready to write your next manuscript, research paper, whatever it may be. What is your coffee, tea, drink order?
Oh, I almost had it with me. I am a London fog girl. I'm a tea girl.
Hmm.
Love London Fog. All
Yes.
right. And then, Blaise, which one were you going to start on? Is it?
I was gonna do the last three on our list.
Great. Sounds good. All right. So last one for me to you. Any last advice for those hoping to become more involved in research? And I think another part of this question that would be in theme with this whole entire interview would also be any advice for those trying to implement more early mobility into the ICU?
Yeah, I think you just have to be brave. And, I spent lots of time at home reading all the evidence. And so that I could go into the ICU and be like, well, this is the evidence-based care. And so that I felt confident and learned a lot like in silence so that I felt really good speaking up in like a really scary environment. And I'm not a research girl, by the way. Like that's my first thing that I've ever published, and now I have a couple of like abstracts out there. I just joined a like critical care consensus group so that we can write some more papers. And I was like, how did I get here? Like, and it's like I'm really bad at math. I'm really bad at statistics. I barely made it out in PT school, if I'm honest. But
Look at you now.
and so it's not that I'm like, I love a good ANOVA. Like hit me with that ANCOVA and the T-test. Like,
My God.
no, no, it's like I care about this thing. And so I can find somebody to help me along the way and advance our practice and help me with the math part. And so you just have to be like brave enough to take that on and learn for yourself and then ask for help when you need it.
That's really good advice.
Yeah, I agree. I feel inspired. Thank you. I'm also not
Yeah.
a research girly, but I would love
Yeah.
to do some more research. But having good mentors who have things in the works who are supportive also does really help.
Man, that's really good advice. I'm jealous. I wish I was your resident or something. I bet they're very lucky. Very, very lucky.
If only.
If only.
Only.
And now to my questions.
I'm
I hope
scared.
you're ready. You should be
I'm sure.
terrified. So, one of these is kind of tailored to you. So, what one thing that Kari does is around West Virginia, we have the different swings. That's become like a nice little landmark for each really neat part of the state. And then you can always take a picture of it. And how many are there now, Kari?
There are 50.
50.
New
Wow.
one opened last Saturday.
Yeah. And so Kari goes out and she goes to all the different swings throughout the state.
This is
And
like
They're
you,
like
so,
they're at state parks, and
yeah.
so like the West Virginia like motto is almost heaven, West Virginia. And so they have like a like VOTEC schools, vocational schools, and these high school students make them all, and it's just like boop, and it says almost heaven across the top, and it's just this big swing.
Mhm.
And so it's just like a tourism initiative. It's not like a swing set.
You're
Okay,
not going to random swing sets. But
gotcha.
which is your favorite, what's your favorite swing that you've been to so far?
Oh, there is one in the southernmost tip of the state.
Mhm.
It took us hours to get down there. I think it's in Bluefield, West Virginia. And like you have to go out of the state and then back into the state to even get to it.
Ooh,
And you can see into, I think, like three different states from there. But it was beautiful.
Oh,
this
nice.
Yeah. So I've been to 48 of the 50 swings.
is
Just
it
two left.
this guy? Like,
That's it.
Yeah, 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 yeah.
okay. I just thought I'd look it up for myself. Maybe I'll take a trip to West Virginia.
And it's all, see, it says make it to all 31 swings. There, no.
No. There's
I'm in like
more.
a
Many.
secret Facebook group for it to like know when they're all going to open. It's the whole thing.
She's dedicated. Very
Very.
dedicated.
Heck yeah.
All right. Second question I got for you. It tis the season. What are you hoping that Santa brings you for Christmas, Carrie? Is there anything you're looking forward to?
Hmm. I asked my mom for gift cards so that I can frivolously spend money without feeling bad about it. Like, yes, I want to go to Ulta on your dollar.
Hmm. Write
Hot.
that down. Write that down for
Send this to
Santa.
my mom. I also asked her, I needed new like cookie sheets, and she's like, "You're really boring." Like, thanks, mom.
Not that bad. My dad literally every year, regardless of which year it is, sends me I personally think the most boring things. Like there's an electric toothbrush. 4 years in a row, he's wanted the same New Balance pair of shoes, and he asked 8 different people for those New Balance shoes because he likes to rotate them depending on what he's doing. And then this year, he asked me for one glove because he lost a glove and he doesn't
Oh,
to me to buy two of them because he's like, well, I already have the other one. It's fine. And I'm like, I don't think I can just buy one glove. I think I have to buy two.
I don't
But
need a pair of gloves, Ashley. I
yeah,
need the left one.
so I'm on the hunt for one glove. Um,
Um,
yeah, we'll see if it happens.
And then the final question, and everyone who's always listened to these know it is the most important question that you're going to be asked during this entire interview.
no, it's not.
Just pretend, please. Please pretend. Do this for me.
I know you, man.
I know. How many Hawaiian shirts do you own, Carrie?
I own zero Hawaiian shirts.
Oh no.
I know.
I might have to cut this residency short. I'm almost done, but
You're gonna drop out.
I drop out. And then like the ab tree is like, okay, what was your reason for dropping? And it was just wardrobe. That's all I put. Wardrobe period.
Yeah. I mean, you have to wear a Hawaiian shirt to work, didn't you?
I did. I dressed up as Thomas Magnum for Halloween.
Oh wow.
And
I
she's
had
like,
some.
wow, did you hear that, Blaise? Did you hear it? She's
She's like, wow, that's so cool. I actually had a patient in the ICU look at me and thought that I was Super Mario. I'm like, one, I don't have overalls on. Two, I'm not wearing a red hat. And three, I'm not talking in an Italian accent. Well, not this red hat. I could. But yeah,
Funny. What do I
so
wish
sorry I missed it.
that's
I
okay.
could get that
Yeah,
complete.
you were in Europe. You were
Yeah.
gallivanting all the way across the world.
That's so
Yeah,
cool. That's
you lucky
where did you
duck.
go?
So this last trip we did Italy and Switzerland.
Oh, how fun. Switzerland was my favorite place I've ever been.
Same.
Oh.
So pretty. Did you do a lot of good hiking?
So it was pouring the rain down this last time,
Mm.
but last went also in April. That sounds bougie. I'm not that
That's
fancy, but
awesome. I
it
mean, you can
happened.
do it on a budget, kind of.
That's my middle name. I
Yes.
figured it out. Um, we stayed in Interlaken,
Mhm.
and then Lauterbrunnen is like the town of 72 waterfalls, and you can just walk the trail and count the waterfalls. That was so fun. And then this hike that we did, it was insane, but it took us to Oceanense, if you've heard of that. The most beautiful place I've ever been. Like snowy mountains, even in April, with the bluest water lake at the bottom. Just stunning.
Ocean and I'm gonna have to write this down. I'm actually going to Switzerland in August. Yeah, with a couple of my family members because one of them wanted to do the Mont Blanc Trail. I think that's what it's called. Like the whole trail. So, but I'm sure we'll stop and like do some other fun things. What was it called? Ocean.
And it's like Oeschenininesce. That's not right.
Wow, that was really good. No, that was actually, I got an autocorrect for it and it doesn't recognize it as a word, but I'm sure it's a place because it autocorrected to it. So I'll have to check it out. Thank you.
Yeah,
Stunning.
nice. Well, Carrie, unless Ashley, you have any more questions, any more rapid fires you can think of?
No, I think I'm good.
Oh yeah. Yeah, well, Carrie, thanks so much for coming on to the podcast and talking about something that's, I think, very near and dear to all three of our hearts for sure. But I think it's going to be really eye-opening for everyone who listens, who isn't familiar with this kind of work in this kind of setting. Um, and I just want to say thank you because I have a fellow mountaineer here with me because usually I'm surrounded by folks who are either from Duke or straight from Miami. So it's nice to not be the one outnumbered this time.
Yeah, let's go Mountaineers.
Let's go Mountaineers. Let's do it.
Yeah, I'm
Yeah.
going to number now. Well, thank you so much, Carrie. We really appreciate your time. This was great.
Thanks for having me, you guys.
Yeah, and maybe
Oh
there
yeah.
will be a part two once you have more of your workout. Who knows?
Oh yeah.
Yeah, we'll see.
Maybe more Hawaiian shirts in the wardrobe or the closet by then.
Maybe we'll plan it next time.
Yeah. Carrie, we just want to thank you for sharing your experience, your insights, and just all the work that you put in to these mobility practices for these ECMO patients, especially during a super strenuous time like COVID. I think this really highlights the importance of safety for these patients who are already in a vulnerable position, communication between the disciplines, and just the amount of care that really is shown whenever we all come together to work towards the benefit of a patient, regardless of how many lines there are, crazy beeps, or, anxiety that lingers between all of us whenever it's a really strenuous situation like this. Uh, I think what really stands out for what Carrie talked about was just the shared belief between everyone on the team that everyone has a role to play. Everyone is significant, including the patient and the care team. And I think the outcomes that she had speaks for themselves. Ambulation rates, discharge home levels, all that good stuff. I think it speaks themselves. And no wonder it's had such a great effect with the 20 different centers that she's coached and all that good stuff. And for everyone who's listening, I hope you enjoyed today's conversation. I mean, it galvanized me. I want to get out there and make my ECMO patients do cartwheels. Maybe not there quite yet. Maybe that'll be in the next article that Carrie publishes. Uh, but really push your patients in the ICU. Advocate for your PT, your rehab department, because you do have a role to play. And keep pushing for safe but progressive approaches to these super complex cases. Uh, Thank you all again for listening. Thank you again, Carrie, for joining us and everything you've done to push the initiative for ECMO mobilization. And to our listeners, thank you again for diving into this topic with us. I hope you enjoyed it. I know that Ashley and I had a really good time with Carrie. Please share this with a colleague, with someone whose mind you think would do well to be prodded by the questions that we asked today. Stay tuned for more conversations that bridge cutting edge research, real world practice, and a sense of humor. All right. See you next time.